Have you ever given what you thought was a perfectly good handover only to be met with a blank stare, an eye roll, or someone who just looks like you've completely ruined their day? Here's the thing, most of the time, it's not actually about you. Hello, welcome back to Paramedic TV. My name's Tommy and this is presented by Pocket Clinician. So today I thought it would be a good opportunity to talk about the issue when it comes to handover. Now, at university, we always get taught about, get a good SBAR handover or ATMIST or whatever you want, whatever acronym you want to use. But we're met with a nurse or a doctor that just isn't interested. And for years, it's been bugging me. And a lot of the time, it is the same nurses and the same doctors that give you not the nicest of feedback. But I thought about it and I realised that actually they've got a lot more going on than probably what we think. So a lot of people do take it personally. I go into A&E and another ambulance crew in the queue turns around and says, "Oh, it's that nurse on today." And actually, we need to recognise what's going on in their shoes, which is why they act the way they do when we hand over a patient. Now, I'm not saying that it's every nurse that acts like this. I'm not saying it's every single shift or every single patient, but it's definitely something that grinds my gears sometimes, and it probably grinds yours as well. So here are my thoughts about why certain nurses and certain doctors in A&E get a bit of a grump when we hand over a patient. So the first thought-provoking point that I wanted to make is that A&E staff are under extreme amounts of pressure. They've got a constant flow of patients coming from all different directions. One from the front door as patients walk in, and also from the back door when ambulance crews are bringing patients in. So they've got to constantly try to triage these patients, work out where they're going to go, try and work out what doctors are going to be treating them, try and find space in areas of A&E that really probably don't exist to put these patients in. And unfortunately, since COVID, there has been this thing called corridor care, which I'm sure we all know about. And I really don't think that nurses are happy with this, but it's the situation they've been put in. So when we bring another patient to just add to that sea of patients in the corridor, that probably doesn't help the situation. Not only that, but that one nurse could be responsible for 20 plus patients. Can you imagine if we rock up to an incident as an ambulance crew and we just have a sea of patients all run to the ambulance saying, "Help me, help me, help me"? How would you feel? And I imagine that's probably what the A&E staff feel when patients are constantly coming up to the desk saying, "How long is it going to be until I next get seen?" Or, "Oh, I'm waiting for an x-ray or a blood test and someone said they were going to call my name. How long is it going to be?" And this nurse probably has a billion things going on in their brain about working out what beds to clear and what patients to put where. And they've got to keep an eye on so many different things because they're responsible for so many patients that they might get a bit grumpy when you rock up all happy and chatty with your friends and your other crewmates, and they're trying to do a million things at once, either on the computer, taking phone calls and things. So you try and hand over a patient and they probably just get a little bit stressed, exactly the same way that we would if we got out of the ambulance and 20 patients all ran to the ambulance saying, "Please help me, I've got this, I've got that." And, by thinking about it in that analogy and comparing that, which I think is quite similar. I mean, tell me if you think that that's completely different, but I think using that analogy can help us understand why sometimes the nurses and the doctors might get a bit annoyed when we come in and try and hand over another patient. The other thought that I had is that A&E was busy before we arrived. Now, we could have started our shift, had a cup of tea, chatted to our manager for 20 minutes about a job we did the other day, and we've got no problems about patients getting in our way because patients don't come to ambulance stations, they go to hospitals. So we've got this luxury almost that no one really knows about. And then we jump in the ambulance, go to our first job, and we're only responsible for that one patient. And then we walk into A&E, hand them over, and then leave, thinking about what's going to happen for the rest of the day. Where in A&E, they've just got a constant flow of people coming in. And it's difficult for us to understand or see where A&E has been in the previous 20 minutes prior to our arrival. It's almost like walking into a movie halfway through. You don't really understand what's happened. Someone could have had a cardiac arrest in resus whilst another patient decided to have a seizure in one of the majors beds and another patient fell off of their wheelchair in the waiting room. And there's only a few nurses and doctors to try and deal with all of those situations, where at least with us, we've only got one patient at a time, most of the time, and we can take as much time as we want with those patients and decide what we're going to do, go through our assessment, yeah, let's take you to hospital, and then trundle in. So if that nurse or that doctor gives you a bit of an eye roll or a blank stare when you're trying to hand over a patient, just remember that we don't know what's just happened in the 20 minutes prior to our arrival. Anything could have happened. It could have been absolute carnage, and they've just sorted it out, and they can finally sit back and take a breather for 2 minutes, and then boom, another ambulance crew arrives. Taking a step back from the way A&E functions, I think also sometimes our handovers aren't as good as they really should be. You know, these staff are busy, they want a quick, succinct 30-second, maybe 1 minute handover of what the issue is today, what treatment you've done for them, and what they might need in hospital. Where I see it quite a lot. I'm sitting in a queue and I'm looking at the ambulance crew handing over, and they're rambling a history, missing quite key information that might be pertinent to where that patient needs to go, whether it's majors or the waiting room. They might not have the observations ready. So when the nurse says, oh, what are their observations? They're pressing buttons on their iPad going, oh dear, oh yeah, they're normal. And it's those little delays that cause the hairs on the nurse's neck to just stand up a little bit because they've got so much things going on in their head. And the last thing they need is an ambulance crew going, oh, hang on, let me look through. Yeah, all of their obs were fine. The other thing I see a lot of ambulance crews do is tell the story, not the problem. And that causes a big issue because it just prolongs the handover. So for example, I've seen it before where a crew has said, yeah, the patient, she woke up feeling absolutely fine. She's had her breakfast and had a shower, and then this happened. That isn't pertinent information for the handover nurse. You want to say, right, at 9 o'clock, the patient had an onset of chest pain. It sounds cardiac. These are the obs. Their ECG is normal. I've given them some paracetamol or whatever you want to do. And that's the reason I've brought them to you today. And really, something like that should really take about 20 seconds. So try and keep your handovers succinct. Try not to ramble a history, and always have the observations on hand, especially allergies, medical history. Just try and remember it in the back of the truck on the way to hospital so that you don't have to sit there waiting for your iPad to load. And then you're going to reduce your chances of having a nurse giving you the eye roll when you're handing over. The other thing that I imagine causes a bit of grumpiness for the nurses and the doctors is we bring a lot of patients to A&E who they feel shouldn't be there. Things like social admissions, minor injuries, frequent callers, and they probably look at them and think, why are they here? There's nothing we can do for this patient. But what they don't realise is there's an element of risk. In fact, quite a high element of risk when it comes to discharging a patient on scene. And I think that most of our conveyance decisions are based on risk a lot of the time, as opposed to the problem itself. For example, if you've got an older lady who has, I don't know, twisted her ankle, and you're thinking, okay, well, she can walk on it. She doesn't meet the criteria for an X-ray, but, you know, she's got a bit of osteoporosis and, you know, I don't want her to be left at home here if she has increased risk of falls. So let's be on the safe side and take her to A&E. Now, an A&E nurse won't think about the decision-making process and the risks involved in leaving that patient at home. So it might cause a bit of an issue when trying to hand over that patient. But what you've got to remember is this. Just explain why you've brought them in. I'm concerned that this patient is at higher risk of falls because now she's limping on her leg, and for that reason, I can't leave an elderly lady at home by herself. And just by doing those things, it can really help. A good example is this. I went to a lady the other day. She's got Alzheimer's and she was found walking in the middle of the road around midnight. She had obviously snuck out of her house, and medically there was nothing wrong with her. She's got Alzheimer's, she has memory problems, so that is bound to happen if her front door is unlocked. So we tried to call her family, there was no answer. We did that for pretty long time. We were on scene for about an hour before we decided, you know what, there's nothing else we can do for this patient. Let's just take her to A&E. And the patient didn't have house keys on her. So there's a big picture here that says, right, it's very difficult to just take this patient back home. One, it's about a 40-minute drive away. And two, she doesn't even have house keys. So we might get all the way there to realise that we can't get into her house. So you can imagine the kind of feeling that I was received with by A&E when I turned up and said, here is an old lady with Alzheimer's who has just left her house. They did roll their eyes and they did ask, why have you not done a set of observations? And the fact of the matter is, as an ambulance clinician, I'm not going to do a set of observations on a patient who I have no clinical concern over. But in A&E, they might want to do all of those blood tests and those ECGs and those observations. So it's just a different way of working. But also, apart from just letting her sleep in the bed, there is literally nothing they can do for that patient until a family member finds that she's not there and then goes to hospital. So it's just about understanding there's a big disparity in what we do clinically for patients pre-hospitally compared to what they do in hospital. And that's absolutely fine. To celebrate the launch of Paramedic TV, I'm giving away a student paramedic bundle. To enter, simply subscribe if you're watching on YouTube or follow if you're listening on Spotify. That's it. And the winner is going to be announced on episode 5 of Paramedic TV. Good luck and enjoy the show. The next point is a pretty short one, but for us, when we hand over a patient, that's the end of the job. But for A&E staff, that's just the beginning. So we're thinking, right, we just want to get this patient offloaded, go to Costa or something, grab a coffee and clear up for the next job. But actually, for A&E, they then have a stream of things to do for that patient. Could be blood tests, x-rays, scans, further investigations, referrals, more investigations on all sorts of different things that we won't necessarily know about because we don't work in a hospital. So just remember, when you hand over that patient in A&E, it might be the end of our journey with that patient, but actually it's the start of the patient's journey with the A&E staff. And there's going to be a lot of things going on that we just leave hospital and don't really think about. So if that nurse gives you a bit of a grump on, just remember that they're not grumpy at you. They've just got another patient that they're going to have to start the whole process on all over again. It's already busy. They're hot. They might not have had a break. And there's just lots of things that need to be done whilst we can just walk away from the hospital. So we might be feeling quite happy because our job is now done, but actually that nurse job has only just started for that patient. The next thought is that they might just not be grumpy at you. We don't know what's happened. Like I said before, we don't know what's happened prior to our arrival. They could have just been verbally abused by a patient. They could have just got a kick in from a senior member of staff about their lateness or their KPIs or something. And they could be a bit grumpy about that. And they don't want to take that out on a patient. It is a lot easier to take that out on an ambulance crew because we are colleagues, and it would be even more unprofessional to take that out on a patient. And so we might just get the brunt of that. And to be honest, I don't think that that's a bad thing. Think about it. If you've just had a meeting with your mentor or your manager and they've slated your times or said that you need to be better at this or better at that, or you've just been to a job and been abused by a patient, there is going to be an element of taking that forward into the next patient. And you might not feel as happy, you might not feel as empathetic, and that's just human factors. And I think that understanding that is really important. So yeah, you can go into the quietest, I just said it, A&E department ever, but you don't know whether that nurse has just been verbally attacked or even physically attacked. You just don't know. So yeah, just smile, be happy, and just understand that we don't know what that nurse or that doctor is going through. So to bring all of this together, I just want to say that there hopefully is going to be some A&E staff watching this, as well as predominantly ambulance staff, but the best teams work together, don't they? That's obvious. And ambulance crews and A&E staff, we're on the same team. All we want to do is do what's best for the patient whilst making our jobs as easy and succinct as possible. Yeah, we work in a different environment. We work in different pressure zones, but we all want the same thing for the patient. Let's think about it like this. The patient doesn't care whether you're wearing a green uniform or blue scrubs. They just want one outcome. They just want to feel better and get treated for their problem. So just remember, if you think that there's a nurse or a doctor that's being rude to you during your handover or might give you a bit of a grump on, it might not be a personal attack. In fact, it probably isn't a personal attack. It's probably one of the list of things that I've just talked about that's causing a little bit of animosity or anger, and that's okay. We have exactly the same. So pop it in the comments. If you're an A&E, doctor, nurse, or other member of staff, pop in the reasons why you might get a bit annoyed at an ambulance crew when handing over. And ambulance staff, let's just open the floor. What's the strangest reaction that you've had when you're handing over a patient to an A&E nurse? So I hope that gave you an insight into my thoughts on why nurses and doctors in the emergency department might get a bit of a grump on when you try and hand over a patient. I hope you enjoyed it. Until next time, I've been Tommy, and this is Paramedic TV.